the Maine Lung Cancer Coalition, our continuation of our webinar series. We are so happy that you're all here to join us today. We are very excited about our topic and our presenters, and really excited that you all are here to join us. So the Maine Cancer Lung Coalition, we are working together to reduce lung cancer in Maine. Next slide. I want to just mention, please, our very important funding partners who make this work possible, so we can continue to spread the word and information and education around lung cancer screening across the state. And our funders are the Bristol Myers Squibb Foundation, the Maine Cancer Foundation, and the Maine Economic Improvement Fund, and we are very grateful for their support. So today, again, very excited to have you all here for our insurance coverage for low-dose CT lung cancer screenings. We have heard in this work that this is some content and information that a lot of people have been asking about, so we have brought in some experts to talk to you about that and their experiences and their work around this topic. So I know that you're going to enjoy their presentation. So we're excited today to have Barbara Wiggin from Maine General and Angela Criswell from the National Alliance. So I'm going to go through just some introductory slides, and then I'm going to go a little bit more into their bios, and then we will then roll into the webinar. So some housekeeping slides. For those of you that joined us on the other webinars, you'll probably be getting familiar with this, but for those that are new today, just some housekeeping slides we're going to go through right now in regards to the webinar logistics for Zoom. Audio lines for non-presenters are all currently muted for all of you right now. Please use the chat box for questions or comments throughout the presentation. If you're requesting CME for this webinar and you did not sign into Zoom through a direct link, or you're watching as part of a group, please let us know that. So please email us at mlcc.mainequalitycounts.org, either during the presentation itself or immediately after, so we can track your participation. QC staff, in regards to our Maine Quality Counts, we work to improve the health of everyone in Maine, and this is a little snapshot of some of our staff. You can connect with us. You can get on our email list to not only for this webinar, but other webinars that we present with our organization. And you can get on that email list at mainequalitycounts.org. And you can see we have other social media sites as well. So for today, just some speaker disclosure and CME information about CME certificates. For the CME disclosure, both our speakers today did not have any relevant financial relationships with the manufacturers of any commercial products and/or provide our commercial services discussed in this CME activity. A CME evaluation survey will be sent after the learning session via email. And we ask that you please complete the survey monkey for that CME within 1 week. And then once we get that back, your CME certificate will be mailed within 1 month completion of the survey. So again, just to reiterate, if you have any questions, please put that in the chat box. We're going to answer them at the end of the session. Just also to know, which I think is important ahead of time, is that if we don't have time to answer, if we have a lot of questions and we don't have time to answer all of them, both our speakers have said that they'll be available to, to answer our questions. And Lizzie is going to be putting together a question and answer sheet. So please know that we will make sure to answer all the questions that you all may have. So today, again, thank you so much for joining us for insurance coverage for low-dose lung cancer screening. And we are happy to have Angela Criswell and Barbara Wiggin. So I'm going to introduce Angela first, as she'll be our first presenter. She is the LCA Senior Manager of Medical Outreach, and she provides technical assistance to advance lung cancer screening best practices. She manages the Screening Centers of Excellence Network, and she coordinates LCA's partnership in the Kentucky Leads Collaborative. She serves on the International Association for the Study of Lung Cancer, Smoking Cessation and Tobacco Control Committee, and previously managed the Kentucky Department for Public Health's Tobacco Prevention and Cessation Program. She has taught political science at the college level for 8 years, has an MA from UVA, and is a certified prevention specialist. We are also very happy to have today Barbara Wiggin. She is the Manager of Imaging Patient Access, Cardiology, Radiation Oncology for Maine General Medical Center. She also is involved in the Cancer Registry and nuclear medicine services as well. She's worked in healthcare for over 16 years, managing multiple departments and developing programs with a focus on ensuring truly improving patient access, quality care, and reimbursement for their services. So I'm going to, at this point, turn this over to Angela. Again, thank you so much for both of you being with us today. And we're going to be doing some screen sharing back and forth, so just to let you all know that. So Angela, I'm going to turn it over to you.
All right, great. Hello, everyone. I am so glad to be with you today, and my thanks to the Maine Lung Cancer Coalition for inviting me to present. And I'm really going to be talking about the coverage landscape. When it comes to lung cancer screening, I'm afraid that oftentimes it can really feel like you are, in a labyrinth, and every which way you turn, there's a dead end here and a dead end there. And it's really, really hard when you've got a patient who, you believe should be receiving a lung cancer screening without any copay or deductible, and they come back with, having to meet their deductible, and they have cost sharing that's imposed on them, and you don't know whether that's an error or not. And so it's really hard to tell a patient when they really need to push back with their payer, or when you need to advocate on their behalf because something has gone wrong in their coverage. So, whether it's you need a secret decoder ring or a treasure map, it sometimes feels a little bit like there's a barrier at every turn. So what I want to do today is talk to you a little bit about the types of plans that are out there and what their requirements are, and which ones cover screening without copay and cost sharing, which are required to and which are not, so that you'll have a little bit better idea as to the types of plans that your patients might have, and therefore what their coverage looks like. So there are so many different paths to coverage, and some of them are dead ends is probably too strong of a word, but some of them have a whole lot of barriers where they do feel like dead ends. So among the types of plans that are out there, you have commercial plans, some of which fall under the Affordable Care Act coverage requirements, and some of which don't. And you have Medicare. You have the traditional Medicare fee-for-service population, and then you have those that are covered under Medicare Advantage plans. There's Medicaid, and I know that's a really hot button issue in Maine right now, and I'm going to talk about it really briefly a little bit later. But you have original Medicaid population, and you have the potential Medicaid expansion population. And then there are some new developments on the horizon as well, such as association health plans that create a little bit more complication in terms of the types of plans that you might find your patients, the types of plans that you might find your patients have. So when it comes to coverage for lung cancer screening as a preventive service, there are two really big coverage umbrellas under which patients could receive coverage for that service. One, of course, is the ACA compliant plans. And then secondly, you have Medicare, arising from a national coverage determination, and that's both the traditional Medicare and the Medicare Advantage plans. So I want to talk a little bit about the ACA first. The Affordable Care Act, or full name, Patient Protection and Affordable Care Act, provides preventive service coverage for several different types of plans. You have the individual and the small group plans that are sold on the state or federal exchange. Okay, so at healthcare.gov, or if your state has their own state exchange, those are covered under the Affordable Care Act. And then also plans that are sold out on the open market. So someone just goes to a broker, they're not going through their state exchange, but they buy an individual plan through an insurance broker. That also is included, with a couple of exceptions I'm going to touch on. You have self-funded group plans. And this is one of the areas where it gets a little complicated, because self-funded plans are exempt from the essential health benefit. But they are still required to cover preventive services, because while there's overlap there, preventive services are included in the essential health benefit. The coverage of certain preventive services, such as those with an A or B rating from the U.S. Preventive Services Task Force, coverage of those is its own distinct protected benefit within the Affordable Care Act. So self-funded plans, even though they don't have to cover the essential health benefit, they do still have to require certain preventive services without any copay or cost sharing, unless they're grandfathered. That's one of those exceptions that I'm going to touch on in a moment. And then you have, the Medicaid expansion plans. And those also fall under the Affordable Care Act in terms of what is required to be included in their coverage. And that means the preventive services. So on the commercial payer side, under that Affordable Care Act, all of the commercial plans that are sold on or off the state exchange have to cover all U.S. Preventive Services Task Force Grade A and B preventive services without any copays or cost sharing. So you don't have to meet your deductible, you don't have to pay co-insurance, okay? With some qualifications. Commercial plans, they have their set network, so the plan holder has that coverage as long as they stay in the network. If they go out of the network, then they will face some cost sharing. But again, if they're in network, they're supposed to have the full complement of U.S. Preventive Services, A or B preventive services, including lung cancer screening if they meet the eligibility criteria without any copay or cost sharing. But of course, there's always a big exception. And that exception is one of the areas where there's a lot of confusion. And these are the grandfathered plans. Now, I'm sure all of you might remember back when the Affordable Care Act was being debated, there was the phrase that often came up, if you like your plan, you can keep your plan. And this, that was, people were very, very unsettled about what was coming down the pike, what was being discussed. And, people who were very comfortable with their insurance plans were really wary of having that replaced with something else that they were unfamiliar with. So the promise was made, if you like your plan, you can keep your plan. But as after the Affordable Care Act passed and as they prepared to begin implementation, they realized that the regulations were going to change the existing plans. And people felt like they had been lied to and so forth. And there was a lot of pushback. And so the federal government created this option for plans to remain grandfathered. Okay, and so these are not plans that are sold on the marketplace, the healthcare.gov marketplace or the individual state marketplaces. They cannot be grandfathered. But those that are sold out there in the open market, like through a broker, and also employer-based plans and so forth, they potentially could be grandfathered. So this was designed to help protect Americans' ability to keep their current plan if they like it. And so, as I said, employer group plans and union policies that were created under collective bargaining, many of those are grandfathered. So, in the legislation that created, or in the regulations rather, that created these grandfathered plans, there were limitations put in place. So that if a plan is grandfathered and they make certain plan modifications, they lose that grandfathered status. So a substantive change to their coverage, significant premium increases, those sorts of things trigger a loss of grandfathered status. And so over time, there are fewer grandfathered plans out there today. The thing is that employer group plans and union plans have a broader array of changes that they can make without triggering that loss of grandfathered status. Unlike the individual plans that are out there, these group plans, employer-based plans, union plans, there's a bigger threshold for them to cross before that loss of grandfathered status is triggered. And as a result, there are more of those out there that remain grandfathered compared with the individual plans. And in fact, the Kaiser Family Foundation has estimated that just under a quarter of covered workers today are still enrolled in grandfathered health plans. So this is still an important barrier for coverage, because these grandfathered plans do not have to cover do not have to meet the Affordable Care Act requirements, such as the essential health benefit or the coverage of preventive services without copay or cost sharing. They are allowed to deny coverage of preventive services, potentially if it was already not included in their plan. They can't retroactively say, we're not going to cover those anymore if that was part of their benefit previously. But if they did not cover preventive services before, they still do not have to cover them, and they don't have to do so without copay or cost sharing. So they can impose the deductible, etc. Now, if it's a grandfathered plan, they are supposed to clearly disclose to their plan holder that that policy is a grandfathered one. They are supposed to clearly state in their summary of coverage benefits, summary of benefits and coverage in plain language what they cover and what they don't. The U.S. Department of Labor has suggested some template language that plans can use in disclosing to their plan holders that their policy is grandfathered. And they don't have to use this language, but this is something that the Department of Labor has crafted as a suggestion. And you'll see in what I've excerpted there on the slide that in that template language, they do specifically address the coverage of preventive health services as being something that is not necessarily required in that grandfathered plan. Okay. The thing is, when it comes to trying to decipher which plans are grandfathered and therefore don't really have to cover preventive services, and which are not grandfathered and therefore are subject to the Affordable Care Act's coverage requirements, where it becomes difficult is that even though this is supposed to be clearly disclosed to that plan holder, the reality is that these arrive as very small print disclosures. And even in the template language, that's one little excerpt from it. There's a whole lot of legal sounding verbiage that people have to dig through. And even the summary of benefits and coverage is so general and vaguely worded often that you can't really tell what is covered and what isn't, and what might incur a deductible and what won't. And so it can become really hard for the patient to figure out, hey, am I supposed to be receiving this without copay and cost sharing? Should I really be, calling my insurer and pushing back? Or is this just the way my plan is? And unfortunately, a lot of people just assume when they get a bill, plan has denied it or has imposed a deductible. A lot of people just assume that it's the right thing, that that's the way it's supposed to be. And if they were told that it was supposed to be covered without cost, then they feel a little betrayed. And a lot of times they won't come back for a repeat screening because they've lost trust in the system, or they have incurred an expense they weren't planning for. And so that clarity on the front end of really knowing where the Affordable Care Act applies, where the 100% first dollar coverage applies and where it doesn't can be really important for that patient on the front end. Medicare. So Medicare does not fall under the Affordable Care Act. So when the U.S. Preventive Services Task Force issued their Grade B recommendation for lung cancer screening, that meant that in the subsequent plan years, that coverage for lung cancer screening would be automatic for those commercial plans that are ACA compliant. But that didn't apply to Medicare. And so what had to take place was a separate, deliberate process that had to be followed. And that did take place in 2014. And that final national coverage determination was released on February 5th of 2015. And it established lung cancer screening as a covered preventive service for Medicare beneficiaries meeting certain criteria. And it would be covered without copay or cost sharing for those beneficiaries. And of course, the criteria, I think probably everyone on this webinar is familiar with it, but there's an age range of 55 to 77. There's a particular smoking history that's outlined, a 30-pack year history. The individual has to be a current smoker or quit within the past 15 years. They have to have no signs or symptoms of lung cancer, and there has to be a written order from an ordering provider. And shared decision-making has to take place, at least for that initial or baseline screening. So CMS outlined a lot of different requirements around the process of screening, not just who would be eligible, but the process that would be followed for that eligibility for that coverage to be assured. So just a couple of the elements for that lung cancer screening itself. There are certain things that have to be in the written order. Specific date of birth for the beneficiary, the actual PAC years, not just a checkoff that they meet or exceed that 30-year PAC year minimum requirement, but that there's a specific number calculated for their PAC year history. It has to outline their status as a current smoker, or if they're a former smoker, the number of years since they quit. A statement that that beneficiary is asymptomatic, and the ordering provider's NPI. And for the screening itself that's billed under GO297 for Medicare, there have to be 11 full months that are elapsed from the date of the last screening. It's once a year for that specific screening. Only one can be claimed and paid a year. For the shared decision-making visit, I do want to make sure that everyone's aware of this. That is GO296, the shared decision-making visit. That can be billed more than once. So let's say you have a patient who goes through shared decision-making and ultimately decides at that time that lung cancer screening was not right for them, and they chose not to be screened. 6 months later, they go back for another visit with their primary care provider, and in the course of that visit, maybe lung cancer screening comes back up again, and the patient seems interested and engaged again. That provider can carry out another shared decision-making discussion, and bill for it once again, and it can be paid as long as it contains all of the required elements that CMS has outlined. So there's not that once-a-year timing limitation for shared decision-making that you see for lung cancer screening. And then, of course, if that patient is not within the applicable age range, the 55 to 77, the claim for either of those, shared decision-making or the screening itself, will be denied. So that you have to make sure that they're in that age range for the Medicare beneficiary. So, Medicare Advantage plans. This is, Medicare Part C. They have to provide the same coverage and benefits as traditional Medicare. So whatever's established in the Medicare National Coverage Determinations, they are held to that. But they are allowed to create their own implementation processes. So theoretically, they could adopt a different coding requirement than the traditional fee-for-service Medicare side. So CMS has outlined, as you're going to hear from Barbara in a little while, CMS has outlined specific ICD-10 codes that have to accompany a claim for lung cancer screening. But a Medicare Advantage plan can say, hey, we want to see a different ICD-10 code to determine medical necessity. So they have that little bit of that flexibility or freedom to set their own administrative rules and processes. But the thing to remember is they do have to cover all of the Medicare preventive services without copay or cost sharing, just like original Medicare does, as long as that beneficiary is in their network. If they've gone out of network, then the cost sharing would apply. So Medicaid, this, as I understand, is a really big deal for Maine at the moment, and I believe that there is a Maine Supreme Judicial Court hearing today, as a matter of fact, to hear arguments on whether Governor Paul LePage's administration has to actually move ahead with the Medicaid expansion that voters approved back in November's ballot initiative. That Medicaid initiative in Maine was supposed to go into effect on July 2nd. But of course, that did not happen since the LePage administration refused to submit a state plan amendment to CMS. That state plan amendment would have established expansion in your state. And then also, I believe he vetoed some funding that would have established funding for at least the first year of the state's share of the expansion. But depending on whatever ruling comes down from today's hearing, and I don't know how long it may be before there's a ruling after today's hearing, but the process has begun today with that court hearing. In theory, the expansion could be applied retroactively to July 2nd. So there are a lot of patient advocacy groups right now that are encouraging people to go ahead and apply for Maine Care, even though right now they will be denied under the current eligibility guidelines. Because once expansion is implemented, once it does move forward, they would then have retroactive coverage back to the date of their application. That's the belief, at any rate. But so what does this mean for lung cancer screening? So once Maine does move forward with expansion, the Medicaid expansion plans must cover the U.S. Preventive Services Task Force Grade A and B preventive services without copay or cost sharing. So that means for those who meet the USPSTF, age and smoking history guidelines, et cetera, they would be able to receive their lung cancer screening without cost for them. For the original Medicaid population, though, they're not included in that, unfortunately. There is no requirement that original Medicaid likewise cover preventive services. So Maine can say for the original Medicaid population, if someone meets those requirements, they can say, no, we don't cover preventive services, unless the state opts in to a special incentive. The federal government offers a 1% federal medical assistance percentage, or FMAP, as an incentive if they do align their benefits for original Medicaid with the Medicaid expansion. And that means the preventive services. If they offer those USPSTF A and B without copay or cost sharing, the same as they do for the Medicaid expansion plan, to those original Medicaid populations, then the state does receive a 1% FMAP incentive. I I have not heard, I'm not sure if that's been part of the discussion in Maine. I know there's a pursuit of potentially a 115 waiver, even for original Medicaid, that would create a bunch of limitations. But nonetheless, hopefully moving forward, there is that option available that would align whatever, that would align the expansion benefits with the original Medicaid benefits. So, what it can feel like ultimately. There remains a lot of I believe, around what's covered. Commercial insurers, even under the Affordable Care Act, can set their own coding rules to establish medical necessity. And that can really leave you feeling like you've been blindfolded, spun around, and left trying to pin the tail on the proverbial donkey in submitting correct preventive service claims for lung cancer screening that will be correctly covered without copays or cost sharing. And so, as I mentioned earlier, when a patient winds up with a bill, you're left not knowing if it's a mistake or not. Did the patient have a grandfathered plan and not realize it? Or is it a coding issue that has triggered it to be processed as a diagnostic service rather than a preventive service, even though it was intended as a preventive service? Is there something that's happened where that, the payer is looking at it as diagnostic and therefore applying the deductible? So Barbara is going to be discussing billing and coding tips and strategies in a moment. And she's going to outline, for instance, the codes that CMS has established. They have a very narrowly prescribed set of codes that they will allow for lung cancer screening. And if you use any other codes along with their codes, they'll deny it, okay? But I do want to mention one thing that we've been hearing about more and more, and that's with the commercial plans. Many of them are now requiring a totally different code that is not included in those that CMS requires, and that's Z12.2, Encounter for Screening for Malignant Neoplasm of Respiratory Organs. So basically, programs are having to create two different coding schemes. Most are setting the ICD-10 codes that CMS has established as their default scheme. And then if a commercial payer denies a claim, they'll go back and try this Z12.2 code, but only after those other CMS prescribed codes have been denied. And that allows them to kind of preserve their CMS compliant coding scheme as their default, since that's probably a large percentage of the patients that they're seeing. But there are some new developments in the coverage arena that create a little bit more complication. You may have heard about the association health plans that were newly approved by the Trump administration, and those are going to be phased in beginning September 1st of this year. And this allows small businesses and the self-employed to purchase these association health plans. And the thing to remember with them, and I don't know with what great frequency we'll see them. I'm not sure how readily they will be purchased, but since they're likely to be at lower cost, I suspect that that at least the self-employed and so forth, many of them younger and healthier may gravitate to them in lieu of the potentially higher cost plans that are available on the exchange. Like the existing self-funded plans, they don't have to cover the essential health benefit. But, and this is a key but, they do still, like the self-funded plans, they do have to cover the grade A and B USPSTF preventive services without imposing any cost sharing. So you may hear they don't have to cover essential health benefit. They, according to what's in the Federal Register, I looked at the final rule, they do have to cover the preventive services. So as long as that patient, if they're in a self-funded health plan, if they're in an association health plan, as long as they meet those USPSTF criteria, that plan is supposed to cover them without any cost sharing. So when you run into barriers, who can help? With the traditional Medicare, the fee-for-service Medicare, you can contact your Medicare Administrative Contractor, Part B contractor, and for Maine, it's National Government Services, and I've listed their phone number and their website. For Medicare Advantage, CMS issued a memorandum just last year that outlines best practices for the Medicare Advantage organizations in requesting and obtaining the information necessary to make timely, appropriate, and accurate coverage decisions. And it notes, and I'm going to quote from them, the plan or sponsor is expected to make reasonable efforts to gather all of the necessary information needed to make substantive and accurate decisions as early in the coverage process as possible. And it goes on, if the plan issues an adverse decision due to the inability to obtain the information needed to approve coverage, the plan should clearly identify that basis and the necessary information in the written denial notice. All that gibberish, what that means is the Medicare Advantage plan shouldn't keep you guessing about what ICD-10 codes are the magic formula for obtaining coverage for G0297, for that lung cancer screening. So Medicare Advantage plans, they're run by commercial insurers. They have some coding, has some regulations, flexibility in terms of what codes they want that might differ from what traditional Medicare requires, but they shouldn't keep you guessing. It shouldn't be a completely opaque process where you're blindfolded and spun around and having to pin that tail on the donkey. Okay, and programs are directed to contact CMS at the email address that I've listed on the slide for more information on that guidance that they've provided to Medicare Advantage plans. And there's a separate CMS email address also that's included in that memorandum. And I can send you the link for the memorandum if you contact me offline. There's a separate email address for CMS Medicare Advantage audits. For commercial plans, if you find yourself facing a pattern of documented unreasonable denials or delays from a payer, you should consider reaching out to the Maine Bureau of Insurance. And I've listed the phone numbers that they showed on their website. I will say I did find the Maine insurance website to be a lot less helpful than that of some other states. Other states clearly outline what providers, who to contact on behalf of patients when there are denials. And Maine, unfortunately, did not have that so clear. But nonetheless, there's the phone numbers there when there are that you can reach out to file a complaint. And also that coveragerights.org website that I've included, that's run by the AIMED Alliance, or Alliance for the Adoption of Innovations in Medicine. And they have some really good state-specific guidance on the appeals process for patients. So if a patient has gotten a denial, if they've been charged their deductible when they shouldn't have, or they believe they shouldn't have, and they've gone through their insurer and filed an appeal and hasn't worked out, the website tells them exactly how they can go through the Maine Bureau of Insurance to try to get that resolved. And this is my contact information. I know that there's an option for you all to submit questions at the end, but if there's something that we're not able to get to, or a question that you have that you'd rather not share via this webinar, feel free to reach out to me via email or give me a call, and I'm more than happy to try to answer your question or do some digging in the background to see if I can find out what's going on for you. Thank you very much. And now I'm going to turn it over to Barbara.
Hello. Let me share my slides here. Okay. Can everybody see that okay?
No, they're not.
No.
How about now?
Yeah.
Yes? Oh, wonderful. All right. Well, thank you so much for everybody joining us. So if you're out there and you're feeling like you can't pass the wizard, I've been there too, and we're always feeling like we're trying to pass the wizard. So the good thing about the Maine Lung Coalition is that we're doing this together, and this is a great group, and we're all here to learn and support. And I think what is great about the leadership here too is that it's an all learn, all grow. So what I'm going to share with you is kind of some of the ways we've tried to work to make this happen for our patients and for our providers that want to share the services. And we really want to hear from you if you have found other things that have worked and stuff, because that's what this is all about. So we're so thankful to have Angela speak, and it's just so great to have such wonderful people working on this for our patients. So thank you for being here. So I'll start off with just talking a little bit about, I remember February very well in 2015 when we first got the first release, because it was like, okay, yay, Medicare is going to cover this. We're so excited. Then you read it, and then it felt like a really big wizard was standing there, right? So, so the first thing that we did to get started was to get some folks around the table. So we started off with number one with our compliance team, because they're really good at reading those CMS regulations, and they really started to run the show for us on all the things that we're going to need to do, and the village that we're going to need to create in order to meet all of those CMS goals. So everything, and I know folks have probably read the CMS, but everything from the registry to the CT guidelines to how the radiologists are going to have to read the exams, that's where our compliance team helped us kind of check those boxes, and they were with us along the way. So if you're just getting started, I would say that's the person to connect with first and start there. We also, of course, had along the table, as Angela talked about, is that the coding can be difficult. So, we have our CMS codes, and then we have codes that private payers might be looking for different coding. And then, of course, revenue cycle, because even though things have gotten much better with the codes, there used to be 3 codes that we all had to all had to figure out. It's much less, but they're going to help you, and then also help you on the back end find out what's going well from what you're collecting on the front end, so that you can fix it moving forward, so that your patients are covered. Because we don't want to have a simple coding error that caused a denial for the organization or for our patients. So as I spoke, definitely if you're just getting started, really dig into those CMS requirements. The other thing that our compliance team really honed in on is that we want to make sure that we meet those requirements regardless of if a private payer requires them or not. Because most of our patients, 55 to 77, they may switch over, and they may switch over in the middle. So all of those criteria on the order, we really wanted to hit upon every single time. We also found, for us, and other folks may find this different, is that just for our providers and for our compliance team that are working these, it was much easier for us to keep the process and the questions the same. What this also helped us to do was to really have consistent data for our cancer registry. So I think some folks are debating on whether to do the registry for just CMS patients or private. So we had chosen to do it for all. And when you ask those questions up front, you're going to have that information to put into your registry already. So you'll have the background data for your patient from the very beginning, which can be very valuable. So if they had private insurance and they weren't in the registry, you won't be able to easily see how many annuals they had before they maybe had a more a finding in their screening. So, and that's kind of what we had chosen. So really kind of standardizing the ordering process for what we found was having a clear order that we were going to use for every lung screening, whether it was a outside physician. We have a paper form, which I'll share with you, and then we did get to go to an electronic form for our in-network providers, and then standardizing the workflow. So with our scheduling team, when they go to schedule the patients, they always have those questions answered, and then on the back end have some checks and balances to check on that coding, like how are we doing? Are any payers pushing back? Who is needing us and who's not? That type of thing. So this is the paper order that our compliance team helped us put together. It is strongly based on the CMS requirements. If folks are outside of these CMS requirements, we do say that if the answer is no to the following questions, we would need to check with the insurance to see if it's going to be covered or not. Just because there's so many plans, as you heard from Angela speaking out there, that at that point, if it's yes or no, the patient wants it, you really have to check with the insurance company to see if they're going to cover it. We've found this to be successful. Our providers have actually liked the checklist. We've gotten feedback from that, and when we built the electronic, that they really want to be asked those questions so they know they hit on them and that type of thing. So so when a provider calls to schedule a patient, if they forget that they need to do this order, our scheduling team is great, and they'll send this to them. So that we don't allow anyone to be scheduled without these things in place. So that's the same thing for electronic order. It's essentially the same information built in. It just looks a little bit different. We were able to add a little bit more in the electronic order and include some more information to help the doctors. Our doctors were great. They really wanted some more information, and this is a link that they can click on to help them a little bit more through the process and to give them some more information. So for CPT codes, so we are seeing on our end that some payers, not all, are looking for a different CPT code. And in the beginning, like I said, there were three. There were the G code, the S code, and then the regular chest code. So now it looks like all of our payers, private payers, have switched to the G code, which is helpful. And then I'll share what we're finding on our end, and I'm sharing this. Please, if you're working this out, work with your revenue cycle team and work with the folks that have contracts with your private payers, because you'll want to verify with them and make sure all of this is it's going to work out for what you have planned with them and what your contract has with them. So, so as you can see, most of what we're seeing is that they're accepting the G code. So we are having success with MaineCare in accepting the 71250 code. They're accepting the medical necessity codes that Medicare requires, but with pre-authorization. So that's what we're finding on our end, and it's worked pretty successfully. I did a quick calculation. We've done about 80 patients that have been on MaineCare, and so that's been fairly successful. So the other thing that we found is that, and like I said, you'll have to talk to, if you have a contract with Harvard Pilgrim, talk to them, but they also seem to want that 71250 code from us. So the other piece on this is I took a quick look, and most of our private payers are also looking for a pre-authorization. So we're getting pre-authorizations on essentially everything on this list except for Medicare. So it's going to feel like you're jumping through a lot of hoops, right? Because you're doing the CMS stuff already. If you chose to go that route, and then you're also getting this pre-authorization, but it's so far it's been working, and we haven't seen major denials on our end, and we haven't had patients concerned about their cost. So with the CPT codes, so those of you that work closely with your revenue cycle team, if you have a payer, once you start talking with them and you find out, they do want a different code, your revenue cycle team should be able to switch that on the back end so that your front end won't have to do funny things like enter different orders or something like that. So I think most revenue cycle teams can do that, and hopefully yours will too. And this, I just want to reiterate, please, if you're working with your teams, talk to your payers, because I don't want to lead anybody in the wrong way. You might have a contract where you don't have to have pre-authorizations, and I would never want you to have to be in that sort of pickle. So please do that. And we talked about the medical necessity for codes that CMS requires. So this is the list of codes for CMS that requires. We did do education with, of course, our coding team and our providers and schedulers on these codes. And as you heard, the horizon is always changing with new codes. So I'm sure we'll be looking at that very soon. and how to make sure that we're hitting that also. So what we have noticed, and what you may notice too if you're getting started or if you're doing this, is that if codes such as cough or shortness of breath get put in there, sometimes on orders, providers might add some more information. We would have that kicked back and have to resubmit. So if you want to avoid that rework, I would just make sure that on the order you just have these codes. And we did have to do that work with our schedulers and our coders on that. So if that's helpful. So for compliance check, so one of the things that we found helpful is that our patients are all scheduled. So we don't accept lung screenings as walk-ins. And so they're all pre-scheduled, and they all go through the process of making sure that that order's filled out. And then sometimes, someone might go through it quick, and we have a imaging compliance team, and 2 days before they start going through the CT schedule, and they'll look at every patient essentially, because we want to make sure our pre-auths are required, but lung screenings in particular, they make sure that that order is filled out correctly, and then they also verify, they checked off 55 to 77, but this patient's actually 80, right? So we have had that happen. So they'll do a compliance check beforehand. They also check on the PAC years. So if a PAC years sounds a little bit off, maybe we might need to do some education, we'll reach out to the provider just to verify and that type of thing. So that's been very helpful. The other thing that our imaging compliance team does is, after the patient has their scan, they know, and then they start the process of entering that information into the registry. So they're kind of the gate holders, and what that helps us with is that we know if the patient had the scan, that their initial registration into the registry is in there. So you can worry about, oh my gosh, I have to catch up with the registry and I have to enter these patients. We found that that's really helpful. And a bulk of the initial information that the registry requires does include, the patient insurance and a lot of registration data that our compliance team has right there. They also enter the information that is on the order, so the PAC years and those requirements. So you get a good solid start with the registry with that. So the other thing that they do is they make sure that for our private payers that they know required authorization, that there is an authorization in the system, and that for Medicare that those Medicare codes are there too. So I can't really say enough about that team. They are just amazing and really have been the key. There's been many key stakeholders in this process, but they've truly been amazing. So then on the back end, after you've done some scans, we always we check our denial. So we were doing this before, but this was really helpful in the beginning to figure out if we were doing anything wrong, especially for coding, when those codes were slipping in that were for cough or shortness of breath, because you could easily fix that and then quickly turn it around. So we do a weekly denial review. We pull anything that's come back from and just make sure that there wasn't anything that we could do on the front end to prevent that denial. And I think for us that has really helped narrow down any gaps that we might have in terms of education, or also the pre-authorization requirements, because sometimes I think that can get a little tricky, because you're thinking, this is a patient that has a Medicare plan, but it's also a private plan and all that kind of good stuff. So that's essentially what we did, and I'll open it up now if there's folks that have questions for Angela and I. And again, just thank you so much to this whole group and all the effort nationwide and statewide to help catch lung cancer at stage 1, because we know that that's what we need to do. So thank you.
Excellent. Thank you both so much. This has been a wonderful presentation with an incredible lot of information. I've been trying to write notes and listen to you both at the same time. And so I will turn a little bit over to Lizzie at this point to see if you have any questions, Lizzie, that you'd like to start with. And then I even have a couple of them myself. So I'll let you, so I'll let you start, Lizzie, and then go from there.
Great. Yeah, just a reminder to everyone, we are going to be posting the recording and the slides to our website, and you'll get a link tomorrow with the survey to complete for CME credit, and also the link to our website where they'll be posted. So you'll have access to all this information. If you have any questions for our speakers, there's a little button on your toolbar that says Q&A. You can type your question right in there, and we'll monitor that and ask those to our speakers. We did have, let me just pull it up here, we did have someone asking to connect with you guys about getting information sent to them about the billing for a second decision-making visit. So I told them that we would be able to send along any of that information. So perfect. But like I said, if anybody else has questions, feel free to type those in, and we will hopefully get to most of them before our time is up today. And we do actually have one so far. What are most of your denials?
Yeah, so I would say most of our denials were a little bit of coding errors when the code for most commonly cough or shortness of breath. And I think at the very beginning, Medicare had said, made some clarifications, or CMS had made some clarifications about what it means to be asymptomatic. So that was very helpful, and we got that out to our providers fairly fast. But I would say definitely watch your coding and work closely with your coding on that. The good part about coding is that you can usually, recode and rebill. So that's a little bit safer. The other part, we're pretty strict with our pre-authorizations. So unfortunately, if you don't get the pre-authorization, sometimes then, you're out of luck. So I would definitely watch coding and then recode if you can, watch that closely and resubmit. And then, of course, work with your private payers on pre-authorizations. That would be the biggest thing. Yeah. Good question.
Do any of the insurance companies cover screening for NCCN Group 2?
That's a really good question. And systematically, no, there's no automatic coverage. We hear anecdotally of individuals advocating for coverage and receiving it. That doesn't mean that it would be without copay or cost sharing. They may pay for it, but not at 100% like they would for a true covered service. But it's on a case-by-case basis. It's really up to the patient and their ordering provider to make that case to the payer. CMS will not cover it at all. It's only the commercial payer that might consider it.
Yeah. Let's see. It looks like this might be a follow-up to the first question. What is the correct code to use for the shortness of breath or cough?
So the ICD-10 code, is the question, so the question is probably about, like, if the patient doesn't have maybe the pack years or the smoking history. So in that case, if the patient just has shortness of breath or consistent cough, what we would recommend is that the patient really should be scheduled for a diagnostic CT. So we would recommend working with their insurance company to get that pre-authorized. If the which is a little bit tricky. So if the patient did meet the pack years and the nicotine, and they really were looking for lung cancer screening, then we would recommend to just have the medical necessity or the ICD-10 codes that meet that on there. Does that help? I can't answer.
I think so. If that doesn't answer your question, feel free to re-type in another question or a clarifying question.
Just to chime in, I think the safest way to proceed when someone meets the eligibility and does not have symptoms that would warrant a diagnostic intervention, then you should as your default, you should use either the Z code for history, the Z87891, and then or the F codes that are specific to cigarettes, and stick to those as your first coding scheme, if you will. And then if there's a denial, then go back and try that other Z code for special screening for malignant neoplasm, and then go on from there. I hear occasionally of really, really strange coding schemes, and I'm drawing a blank right now, but there was one Blue Cross Blue Shield policy that was looking for some other Z code related to a special respiratory screening not otherwise classifiable. That was the only time we had ever seen any plan that wanted that particular code. So if you stick to those CMS codes or the Z code that I mentioned, you should most likely not have any problem.
And what is the charge? We have a question. What is the charge for the decision-making visit? Do you know?
What is the payment amount?
I think that's the question. Yeah.
If you want to go on to the next question, I can look. I've got that somewhere here.
Okay, great. Yes, that is the question is, what is the charge? So I will move on to the next question. We'll come back to that one. On the main general health order, the years since quitting requirement is shown as less than or equal to 15 years. My understanding is that the criteria is within 15 years means that it's less than 15 years. Can you please clarify?
Okay, so I think the way our compliance team was reading it was that we could put less than or equal to 15 years. That was the way that we read the standard, but I can certainly take a look back. It never hurts to revisit. That's never going to hurt you. So that's a good point, and I'll definitely take a look back at that. Thank you so much for bringing that up.
And we have a follow-up to the charge for a decision-making visit, which is, does anyone know what the charge is for the radiologist? I'm guessing it's abbreviated, RAD, to read the screening.
Yeah, so what I found my list for 2017. I'll have to go back through my files to find 2018. I didn't have it handy, but for shared decision making, the OPS payment rate is $70.23. Of course, that's different from the Medicare physician fee schedule payment, which I can look that up. It will vary depending on where you are because of the geographic pricing index. For the lung cancer screening itself, the OPS payment rate last year was $59.84. For 2018, there wasn't a huge change in those. It dropped a little bit, but just by pennies. And then for the Medicare physician fee schedule, the reading radiologist would be paid under the Medicare physician fee schedule. And I'd have to look that up. I'm afraid I don't have that handy. But.
Great, thank you.
Yeah, and that's all the types of questions I have so far. Jessica, if you have a couple others, we can certainly go to those.
Sure. No, I just, to Barbara, I just had a question in regards to the compliance check. Mm-hmm. Can you say again how, that whole component, which I think is a wonderful checks and balances to your point, right? To really identify any issues prior to even having the screening, which I think is very invaluable. So how far did you say in advance they will do that? I was just trying to catch the time, because I'm sure, again, you've kind of done some process improvement around this and tried it different ways and find. So what have you found is a good time frame that gives you enough time or gives that compliance team enough time to be able to, if there isn't a prior auth, get one, you know what I'm saying, in that time frame for the patient, so that the patient obviously feels that this is a very seamless process and that, how that works. So.
Yeah, great question. So we start 2 days in advance. So that gives you the next day to fix anything that you might need to fix with either the provider's office or for a pre-auth or anything like that. So they'll start 2 days in advance and go through everything, and then work on fixing anything that needs to be fixed the following day, so that next day, essentially that third day, you have everything ready to go. And if you have to contact, that gives you time also to contact the patient if for some reason you couldn't get the auth or that type of thing. So that's been really helpful. And we found if you go too far in advance of 2 days, there's just we get so many CT add-ons that
that's my point, right?
Yeah.
Yes,
So
exactly.
We do another, so they'll run the schedule again at 2:30, and what we've asked our scheduling team is to not schedule any CTs after 2:30 before 12, because at 8 in the morning or they'll run it again to see if there's any add-ons, and then at least you have until noon to catch anything. So they're always working really quickly to review everything. It's a fast CT in general is hard
Right.
to make sure you're gonna get reimbursed for your services. So it's, I would say probably 40 CTs a day. So
Yeah, that's perfect. That was exactly my reason for asking that question, is because not only do you have the ones that are scheduled, but you know, lung cancer screening is not all you do, right? So there's all these different other components and CTs that you're trying to fit in there. So that's a great point of how you've kind of looked at that and, you know, made some adjustments based on that. So that's great. So I can see that we are just about, Lizzie and I are on the same page here. We are at our 1 o'clock time. And again, if there's any questions that you all have, you know, please feel free to reach out to us. You can reach us at the Maine Lung Cancer Coalition.org. Please visit our website. All these different webinars that we've had 6 of them this year, looking at all these various components that you've heard Barbara and Angela talk about in regards to requirements and eligibility, and we've, you know, all kinds of different topics. So feel free to go to our website, click on that MLCC page and scroll to the bottom and look under Learning Archives. And you will see all these, including this webinar today, will be archived there as well. You'll have the recording. You also have the slide deck. And again, we're so grateful. Thank you so much to Barbara and Angela. It's been a pleasure working with you both through this whole process, and we really appreciate your expertise and your knowledge and experience in sharing that with all of us. So thank you so much for joining us today.
Yes, thanks, everyone.
Absolutely. And thank you all of you for joining us today and taking time to join us on this topic. We know that this hopefully has been really helpful to you all. And again, don't hesitate to reach out to us, to Barbara or to Angela, to answer any questions that you may have. So thank you all, and we'll say goodbye and have a wonderful